Okay, you guys are good to get started.
All right. Good evening, everyone. My name is Farris Ahmed. Thank you for joining TNVIRJC. I'm joined with my classmate Syed Aftab. We are both second-year students at Rowan Virtua School of Osteopathic Medicine in South Jersey. We really want to thank our faculty mentor today, Dr. Frank Kowalkowski from the University of Pittsburgh Medical Center, and he'll be helping facilitate our discussion. Today, we will be presenting the Chocolate Touch study, which is a randomized trial of chocolate touch-coated balloons compared to Lutonix drug-coated balloons in femoropopliteal lesions. To our poll everywhere, you can use that, or you can text as instructed. It might be easier later on in the presentation if we have there will be a QR code, which is a scan, and you can join the polling from there. So in terms of what we'll be talking about today, I'll be giving a background on femoropopliteal disease, the epidemiology, and then I'll provide a case example just to give you a better idea of how to treat it. Syed will lead the article discussion, and then throughout this presentation, Dr. Kowalkowski will moderate it, and then he'll also lead the question and answer session as well. I'll start off by talking about peripheral arterial disease. This is the big umbrella term that's used in interventional radiology and in vascular surgery to go with that, for claudication that occurs in the lower extremities. And this is due to narrowing of the arteries and veins, and this would reduce blood flow to organs and tissues. So in the lower extremities, the blockage of arteries in the lower extremities would cause ischemia and necrosis. Particularly in the feet and toes, obviously, because those are the most distal regions. And so this blockage in the lower extremities, it's due to some sort of plaque buildup, like a cholesterol buildup, and we'll talk more about that in a bit. Big four causes for PAD: hypertension, cholesterol, hyperlipidemia, and smoking. So it's very imperative to control these disease processes to prevent PAD. And just stepping back from that, talking about our atherosclerotic disease as a whole, this is just the buildup of fat, of plaque in the vessels and arteries and veins, and not just in lower extremities, but also just throughout the body. So this can lead to heart attack if it particularly affects the heart. It can lead to stroke if it's affecting vessels in the brain, and then limb loss if it's a result of peripheral arterial disease, or chronic limb ischemia, which we'll discuss. So limb loss is one of the worst outcomes for PAD. This is just a schematic here. So the yellow buildup is going to be in the vessel. It's preventing blood flow to the feet and to the toes. And then that's going to be causing ischemia and necrosis to those distal regions. So everything pretty much distal to that lesion, to that blockage, is going to cause some sort of tissue damage. Now, chronic limb ischemia, which is it's also called critical limb ischemia, but that's a term that's not really used anymore. The correct term nowadays should be chronic limb ischemia. That is the severe form of PAD. And what's interesting about this and what's key for diagnosis is the presence of pain at rest, and the presence of ulcers and gangrene. So there's so much tissue damage that's in the there's so much tissue damage that's in the feet and the toes, is that it's going to affect the tissues in the feet and in the distal area. And there's presence of pain at rest because the claudication is so severe in this vasculature that it's not just that movement like how it would be in PAD in more minor forms of PAD, but now the presence of the symptoms at rest is what really differentiates it to CLI. Why this is important to study. So this affects approximately 2 million people a year and has a very high mortality rate within 5 years. And that's just because of the chronic limb ischemia, but that's because of that atherosclerotic disease process that can occur, that can affect other organs and lead to end organ damage. And specific to the limbs, 40% of cases lead to amputation within 1 year. So that's obviously something that you want to prevent if there's CLI. The symptoms of CLI, so you're going to have decreased sensation, decreased sensation in the legs and foot sores that do not heal properly. Again, that tissue damage, so there's going to be gangrene, black, dead skin, and absent weak pulses in the feet because of that lack of vasculature and blood flow. In terms of diagnosing CLI, the gold standard for CLI is digital subtraction angiography. That's what's, I guess, the main way to diagnose it. MRA is magnetic resonance and arteriography. That's the cheaper, faster, safer approach that can be used, and CT as well. So this is the Rutherford classification of CLI. You'll start seeing that the pain at rest that's starting at stage 4 for this disease, and also ulcers and gangrene at stage 6. For our study that Syed will be talking about, it applies to stages 2 through 4. So you will still see patients in this study that are going to have ischemic pain at rest. But yeah, so stage 5 minor tissue loss, again, that's because of that tissue damage that's going to be occurring. Ankle brachial index is also a good way to diagnose and to track CLI throughout the disease process. A lower number is going to be indicative of more severe disease, and that's because to get this value, you're going to be dividing the blood pressure in the ankle divided by the artery, divided by the blood pressure in the arm. So then a lower number will be indicate more lower extremity damage. Just some example angiograms that we have here. You're going to have more occlusion in the top panels. And then after stenting is what you see in the bottom panel. So there's more blood flow that's present. And these are kind of focusing on the anatomical area of interest throughout our study, throughout this study, sorry, the TACLO-TOUCH study, looking at the femoropopliteal arteries. Here is just an example MRA. This is just a MRA you would use throughout a snapshot in time. So it's not just, this is just one image that we are particularly looking at. It's throughout like a various, throughout time. So this is one image of like 70 images that you would use for an MRA. Now we'll be talking about femoropopliteal disease. It's a subset of PAD. It affects the femoropopliteal artery. We'll be looking at this anatomy in a bit. It's the most common site of PAD, and it's due to claudication in the femoropopliteal arteries. That's going to be located in the calf muscles. So this similar disease process, you're going to have plaque buildup in the femoropopliteal disease, in this disease, and then it'll affect vasculature distal to it. For this, you'll be checking for lower extremity pulses, and again, the pulses distal to this to the claudication, the pulses should be absent, so that would be the popliteal and distal pulses. But then the femoropopliteal pulse will be present because that's proximal to the claudication. That's going to be in the femoropopliteal artery. This is a good schematic to see exactly where we're looking at in terms of anatomy. You're going to have the femoral artery is running down the leg, and then that turns into the popliteal artery. That branches into the anterior tibial artery and posterior tibial artery. So the lesions are mostly occurring, but kind of like right behind the knee when it's turning from the femoral artery to the popliteal artery. This is an angiogram looking at that, pretty much what I just described, the popliteal artery, which branches off into the anterior and posterior tibial arteries. In terms of who it affects about 10% of people in their 60s and 70s, and 20% of people above the age of 80. So that's a result of occlusion and plaque buildup that's going to be in the femoropopliteal artery throughout as you get older, and it's most common in African Americans. In terms of pathophysiology, it's similar to what we've discussed so far. Again, it's just the atherosclerotic buildup specific in that artery, and specifically complex interaction between cholesterol and the vascular cells. So that would just mean that specific buildup of the plaque of the cholesterol right against the vessel walls. And then this buildup is going to be inside of the arteries. In terms of clinical presentation, you're going to see recurrent fatigue, cramping, and pain. That's because of the lack of vasculature there. Pain and presence of symptoms at rest. That's because of the that would be in the case of where there's higher levels when you're in a higher classification of CLI. So stage like 4, 5, and 6, you're going to have pain at rest, possible ulcers and gangrene because of that tissue damage. In terms of the diagnostic workup, one of the great ways to diagnose this early on would be that ABI measure, the ankle brachial index. Again, looking for a lower number because a lower number would indicate lower blood pressure, lower blood flow in that lower extremities because you're dividing the lower extremities by the upper extremities. And then the next step would be that CTA, MRA, more imaging. And then the third step would be something more invasive, like a catheter, angiography, or some sort of surgical intervention. In terms of treatment, yeah, you're going to see pharmacological intervention, antiplatelet therapy, surgical intervention, endovascular treatment, some sort of stenting, and then drug-coated balloons. That's underlined, obviously, because that is what our study focuses on. And then this is just a case to really keep the audience engaged. This patient comes in with claudication of the lower extremities, as shown in this MRA. Vitals are there. And then what is the best course of action? Surgical intervention, angioplasty stenting, and watchful waiting. So you can use this QR code to log in. We've had some technical issues, so you can try logging in and then let us know what you think.
Just posted the poll everywhere in the link for the audience.
All right, thank you.
I think it says, for me, it's saying it's waiting for the presentation to begin.
Yeah, it's also saying that for me too.
Oh, yeah, it just started.
It's good now?
Yes, it's good now. Thank you.
Okay, perfect.
Let's give this like a minute for the poll. right, let's looking close between watchful waiting and angioplasty stenting. Kind of depends on how you treat it. We were looking for angioplasty stenting because of that presence of the claudication. But yeah, it just depends on the case and how the patient presents. And that's going to be kind of segue into our discussing our article and how to approach patients of that nature.
Thank you, Farris, for that great background. So now we'll be transitioning the presentation into the talk on our clinical trial for today. So our paper is titled Randomized Trial of Chocolate Touch Compared with Lutonix, or the first generation drug-coated balloon for femoropopliteal lesions, formerly known as the Chocolate Touch study, conducted and published in 2022. So just some background on the Chocolate Touch study. It's the first direct comparison of a first versus second generation drug-coated balloon. It's a prospective multi-center study between the United States, Europe, and New Zealand. It's also a randomized one-to-one trial, and it was funded and directed by Trireme Medical. So Trireme Medical is a medical device company based out of California, and they develop many different therapeutic mechanisms for the treatment of complex vascular diseases, such as the Chocolate Touch device here, as well as some other coronary stent systems and percutaneous devices. So starting off our discussion with the Lutonix drug-coated balloon. It's the first generation drug-coated balloon. It's described as an over-the-wire catheter with a drug-coated balloon fixed at the distal tip. The balloon itself is coated with a specialized formula that includes the drug paclitaxel, a known anti-proliferative agent. Paclitaxel is also highly lipophilic, insoluble in water, and is evenly distributed across the working length of this balloon. The formulation allows for the release of paclitaxel to the tissue of the vascular wall during inflation. And the device itself has a low profile tapered tip to facilitate movement to and through a stenotic vessel. And it also has two radiopaque marker bands throughout the working length of the balloon and are found under the proximal distal ends of the balloon to allow for fluoroscopic visualization during the procedure. And the indications for this use are percutaneous transluminal angioplasty after pre-dilatation of lesions up to 150 millimeters in length in superficial femoral or popliteal arteries with vessel diameters of 4 to 6 millimeters. And this image greatly shows how this process works. So you can see an A that represents new intimal hyperplasia causing an in-stent restenosis. And in B is where the drug-coated balloon is brought to the lesion site. Once it is in the correct position at C, the balloon is inflated for approximately 30 seconds, releasing paclitaxel. The balloon is then taken out, and the drug now works its way throughout the artery wall. And paclitaxel is noted to work over the course of several days to counteract cell regrowth. And in E, you could see how the drug release itself includes a mixture of lipophilic drug as well as a hydrophilic spacer or excipient that facilitates the uptake of paclitaxel. And then for Lutonix, the specific excipients are polysorbate and sorbitol. Now comparing that with the Chocolate Touch drug-coated balloon, it's also a tapered tip that allows low entry profile for lesion access. And it's specifically constructed with pressure relief grooves to prevent dissections from going. And during inflation, marked by number 1, the cage causes the balloon to form a series of segmented pillows throughout the length of the lesion. And then the nitinol cage in 3 expands with the balloon and protects the vessel from stress and dissections. In addition, the pillows allow force to create minimal dissections needed for effective dilatation. And overall, these features allow to increase the surface area by approximately 20%, potentially allowing more drug delivery and limiting vessel damage. And similar to Lutonix, the Chocolate Touch main pharmaceutical ingredient is paclitaxel. However, it's at a slightly greater dose density at 2.95 micrograms compared to 2.0. And from what we know, paclitaxel works by preventing the depolymerization of microtubules during the G2M phase of cell division. And then for this device, the excipients are purple gallate and an inactive substance. And the indication for this device is the same as Lutonix. So now going into the study itself, I'm just going to be reviewing the inclusion and exclusion criteria. So the majority of patients were adult patients greater than 18 years old, specifically in the Rutherford class 2 to 4, as Farris was talking about previously. They all presented with claudication or ischemic rest pain. And the inclusion criteria was specific for angiographical significant stenosis of greater than 70% within those specific arteries. And there was also a maximum roll-in of 50 patients. And patients were also excluded on certain criteria if there was presence of perforation, dense calcification, a dissection, or if they had previous procedures such as a graft or stent or a in-stent restenosis treatment. So some additional methods to cover, the patients underwent, as I said previously, a 1-to-1 randomization ratio. Each patient was provided written consent. The safety of patients was overseen by an independent monitoring board. An independent clinical events committee educated all potential endpoint events. And there's also a separate clinical events committee, as well as laboratory personnel that were blinded to treatment assignment. Now to get into the meat of the clinical trial. The clinical trial was assessed through specific efficacy and safety endpoints. So for efficacy, the main point was drug-coated balloon success, or drug vessel patency assessed by peak velocity ratio less than 2.4. So a peak velocity ratio is defined as peak systolic velocity in that particular area of interest divided by systolic velocity in the upper normal proximal segment. So for example, a ratio of 2 denotes a 50% stenosis. And as that ratio decreases, for example, post-treatment, that would denote a decrease corresponding in stenosis. And the patients were also mandated to undergo a ultrasound analysis at 30 days, 6 months, as well as 12 months. And the primary safety endpoint for each procedure was freedom from major adverse events. Major adverse events were defined as a composite or group of target limb-related death, amputation of target limb, as well as reintervention of the target limb. And I also included the secondary clinical and safety endpoints. So what are the goals of this analysis? So primarily meeting the primary trial success of non-inferiority of the Chocolate Touch drug-coated balloon, finding what the exact efficacy is of this device, describing the interaction between atherectomy, use and outcomes, as well as assessing mortality in the Chocolate Touch arm compared with the Lutonix drug-coated balloon from a time point of 1 to 3 years, and also concerning any other secondary endpoints as either supportive or opposed to this use of this newer modality. So this is the subject disposition flow chart, basically summarizing how the patients were divided up into 2 different groups. So the end patient number was 313, divided into Chocolate Touch and Lutonix, 152 and 161 respectively. And then it was able to track the number of patients that were still involved in the study at 30 days, 6 months, and 12 months. And I just have a question for you guys. Nice. So just to go over this question, the study was noted to meet the pre-specified conditional power within its first 256 patients. And then they enrolled an additional number of patients to allow for a loss of 50% in follow-up to a total of 313, including 20 roll-in patients, meeting the study power of 85.6%. But we'll also see what the end results were. So to go over the baseline characteristics, so as Farris mentioned, hypertension, hyperlipidemia, and diabetes mellitus are very important risk factors for patients affected by critical limb ischemia, as well as body mass index. So that matched up pretty well in both categories, as well as smoking. And as the guidelines for the trial mentioned, the classification was restricted to class 2 to 4, and the majority of the patients were within class 3. And the ankle brachial index was noted to be at 0.71 and 0.75 respectively. In terms of lesion length, vessel diameter, diameter stenosis, they're matched up pretty well between both groups. The inflow treatment location as well was in the majority of cases within the iliacs. And for reason for treating with atherectomy, the majority reason why was standard of care treatment, as we'll discuss later on. And then now going into the outcomes. So for the primary efficacy of the true drug-coated balloon success, the chocolate touch was able to show non-inferiority at 78.8% compared to 67.7% for Lutonix, which was great. And primary patency was also very similar at 78.8% and compared to 67.7% in Lutonix. And as well as primary safety outcomes or freedom from any major adverse events, as I talked about previously, for example, like reintervention or amputation. 89% of patients were free from that for the chocolate touch drug-coated balloon group compared to Lutonix. So that was also great as well. And then for all-cause mortality, only one patient succumbed to those, and for a chocolate touch, and then 2 for Lutonix. So that was also great as well. And then just have another question for you guys. It seems like the majority of you are familiar with this. So this study also employed the Kaplan and Meier curves. So Kaplan and Meier curves, they're used for the primary efficacy and safety endpoints for this trial. You can see how the use of the chocolate touch drug-coated balloon allowed superiority or showed superiority in this context, as well as showing similar safety measures in terms of freedom from target limb related major adverse events. And just as a background for those who don't know, Kaplan-Meier curves are a visual representation of a survival rate, and the uses of all cases are within a series. And it is based off of observed data, and the probability of survival is constant within each interval, although that may be subject to change. And from what I learned, the likelihood of the event happening is the same for participants enrolled early and as well as later on. And a few limitations that I found of this method is that it cannot accommodate for time-dependent variables and cannot control for covariates or which are other variables that may be involved within the analysis. And these are the mortality results. So in tracking for mortality for the patients post-procedure from 1 to 3 years, a post-hoc Bayesian predictive analysis was used. So that's described to be a piecewise exponential distribution with an assumed probability. And it uses something called the Bayes theorem to update the probability of a hypothesis as more information becomes available. And it is widely used today for clinical situations, reliability engineering, as well as heart transplant data. And in this trial, it was implemented to predict the future mortality rates of patients at the 2 and 3 year mark. And this was derived from mortality rates in a different study of paclitaxel treated patients within a meta-analysis of randomized controlled trials. So in that separate paper, over 2,000 patients and 386 deaths were noted from paclitaxel containing devices with a 4-year mean follow-up. And they were able to find a 38% increased mortality risk at 5 years with use. So with that data, they extrapolated it with this trial for the comparison between chocolate touch and paclitaxel drug-coated balloons. And essentially this graph shows us that there is a lower difference in mortality with the chocolate touch use. However, that difference is not significant compared to Lutonix. So some key takeaways that I took from this study: the second generation drug-coated balloon should be considered in future trials as an effective and safe device for femoropopliteal lesions. Chocolate touch drug-coated balloon may have similar efficacy and safety due to its higher dose of paclitaxel, along with its drug delivery with pillows, grooves, and a nitinol cage. These devices may reduce a number of major adverse events and mortality within treated patients. However, further investigation is needed. And other devices such as drug-eluting stents or impact admirals should be compared and tested against chocolate touch drug-coated balloons, and also in other clinical scenarios as well, such as fistulas. And to go over some of the limitations of this study, so what I noted was that within the patient population, 91% were white and 57.5% were male. And that may not be generalizable to the majority of patients that are affected by critical limb ischemia. So what I found was that African-American patients, particularly women, as well as Native American Hispanic patients, have the highest rates of peripheral arterial disease. We were also noting the choice of atherectomy and the use of distal embolic protection was at the discretion of the operator. There was also an interruption in trial in the United States for 6 months due to paclitaxel warnings and also COVID-19. There was also 34 investigational sites across 3 continents, so that can also allow for room for error in terms of clinical assessment and technical procedural style. And to this date, we still do not know the exact mechanism of chocolate touch drug-coated balloon in terms of its non-inferiority compared with Lutonix. And now I'll leave it to Dr. Kowalkowski to talk about some of his takeaways that he took from this clinical trial.
Yeah, so just some, so first, a great job, Farris and Syed. And then just some discussion points that I took away from this study. So what, I guess, why does everyone, what are your opinions as to why chocolate touch was superior in terms of patency and efficacy in this study compared to the Lutonix? Because there were a couple things. First, the amount of paclitaxel in the chocolate touch is more than in the Lutonix balloon, and also the IFU, or instructions for use, in the chocolate touch actually have more aggressive sizing of the balloon. So there may have been more aggressive angioplasty in terms of sizing of the balloon. It was 1.1 to 1 compared to 1 to 1 for the Lutonix balloon. So those are a couple things. You know, could it have just been the higher dose of paclitaxel, and that is the reason that we saw better results for the chocolate touch? I don't know. What does everyone else think? Yeah, and also, they talk about, the pillowing and the grooves in the chocolate touch may also increase the surface area, which could, in theory, deliver more dose or a higher dose of the drug or higher over a larger surface area. So those are a couple things. Another discussion point I took from the study, which they briefly mentioned that in the middle of the study, they actually randomized patients. They incorporated atherectomy in the treatment of some of these patients in the study, and then randomized after atherectomy, and didn't really describe, why they chose to do atherectomy or what types of atherectomy they used. So I think, future directions, you could look at the role of atherectomy in the patency, femoropopliteal disease, versus maybe atherectomy alone, or atherectomy plus or minus a DCB, and look at the patency there. And then, are some types of atherectomy better, provide better patency and safety? There's rotational atherectomy, laser atherectomy. Laser atherectomy is kind of a new big thing. A lot of people are using laser atherectomy as opposed to rotational atherectomy. And also, Syed mentioned this briefly in the future directions. I would like to see, a study looking at the chocolate touch in dialysis interventions, such as, AV fistula, AV graft work, and see what the patency is there. And also the use of chocolate touch balloon in in-stent stenosis as well. So those are a couple things. Anyone else have anything to add, or any questions?
Yeah, I found the increased surface area of the chocolate touch really interesting when I was looking for just reviews of this article. Just the pillowing technique, and how that, I think it was increased the surface area by 20% compared to traditional models, which I found really interesting. I would just, I don't know if anyone would know this. I'm just a little curious on how exactly the pillowing technique enhanced the surface area by that much, and why specifically, like compared to like conventional models, like what was traditionally used instead of this pillowing technique.
Well, typically, I mean, most angioplasty balloons are just a mounted balloon, a mounted balloon on a catheter. They're not constrained in that nitinol cage like the chocolate touch. So that's the biggest difference. The chocolate touch is constrained in a nitinol cage, which again creates those pillowing and grooves, and that's basically what increases the surface area theoretically.
I think John has a question.
Yeah, I see someone with their hand raised. Yeah.
I'm just curious if practically the grooves make it easier to locate the balloon on, or keep the balloon located on the point of claudication because of the texture added due to the nitinol rings, or if there are any other.
You mean as far as the visibility on like fluoro imaging?
Yeah, or I imagine like due to the texture, there would be less movement of the balloon potentially during inflation.
Oh, I see what you mean. I don't know that that's the case. Honestly, I can't say I have used the chocolate touch balloon in practice myself. I've used the Lutonix balloon many a times. And yeah, sometimes if you don't have the balloon well centered in the lesion, it can, what we call watermelon, and push forward or backward. But sometimes you just have to hold manually hold the catheter as you inflate the balloon. But once you have the balloon inflated, it doesn't move. So I don't know if that's answers your question.
Yes, thank you.
Mhm. Yeah, so as far, I see someone in the comments here asking about how often DCBs are used in daily practice. Basically, in my practice now, we don't do much PAD, but we do a lot of dialysis interventions. We use it quite a bit. There's been, many studies showing, improved patency, in not only PAD, but dialysis interventions as well. Especially when you have, this happens quite a bit in dialysis interventions where you have, for instance, you have a brachiocephalic fistula, and they develop recurrent stenosis at the cephalic arch, and the patients come back every couple months with that recurrent stenosis. Sometimes, using a drug-coated balloon can give an extra 2-3 months of patency, which I think helps. I mean, patients, do not want to come to the hospital every other month for a procedure. So the longer you can get them, can get intervention-free patency, the better. So yeah, DCBs are used quite a bit in real practice. So. Anything else? Anyone? Yeah, someone asked in the comments here about the cost. And yeah, that is one thing you have to take into consideration. DCBs are significantly more expensive than plain angioplasty balloons. So I don't use them willy-nilly. I don't use DCBs, for instance, if a patient comes, again, we do a lot of fistula work. So they come with a venous outflow stenosis for the first time. And it's, and it responds well to plain angioplasty balloon. Then I usually just stop there. But again, if this patient keeps coming back frequently, with the same issue, then that's when you think about using a DCB, and then sometimes even stenting as well.
I have
Going
a
along.
question. Oh,
Go ahead.
sorry, Farris. I was just gonna ask, what role do medical management and lifestyle modifications play even after endovascular treatment? And like, how have you found that we can better educate patients on this?
Yeah, I think that is very important, and I saw that in the comments earlier. And yeah, the first step should be someone with mild claudication. The first step should be exercise program, and smoking cessation, and medical management. So in my fellowship, when we did a lot of PAD, we would always that would be like the number one thing, is educating these patients that they need to stop smoking. They need, lifestyle changes, eat a healthier diet, get them on an exercise program. That would always be the first step, because that is extremely important. And like you said, it is extremely important even after we do an intervention do interventions on these patients, that they continue to be on an exercise program, continue to, smoking cessation. All those things are extremely important. And also their diabetes management, making sure their HbA1c is at goal. Those are all very important things.
I'll go with my question next. I was also interested. I've seen that drug-eluting stents before. And I was like, what are your thoughts on drug-coating balloons versus drug-eluting stents? How comparable are they? Is there like a preference in the field?
Well, a stent is kind of a permanent thing. So a stent, once you put a stent in a patient, that is that's with them forever. So so stenting is typically stenting is usually reserved for lesions that are recalcitrant to balloon angioplasty and drug-coated balloon angioplasty. And also as far as SFA disease, if you have a very long segment occlusion or a very long segment stenosis, those oftentimes very long segments, a lot of times do require stenting. More shorter focal lesions respond much better to balloon angioplasty. But as far as regular stents versus drug-eluting stents, that I think there needs to be more more studies comparing right now. I think it's kind of basically like operator dependent, whether you're going to use a drug-eluting stent or a regular stent, and then whether you're going to use a covered stent versus an uncovered stent. These are all things to consider, but we like to reserve stenting again for lesions that are recalcitrant to balloon angioplasty.
Thank you.
Any more questions from the audience? Feel free to message me if you'd like me to read it out loud. Or raise your hand. But looks like that's everything. Thank you so much for a great discussion, Farris, Syed, and Dr. Kowalkowski. It was a really informational presentation. I hope everyone learned a lot. We're going to be posting the recording of this on our YouTube channel, so stay tuned for that. And if there's nothing else, thank you everyone for being here. Have a great night.
Thanks for having us.
Thank you.
Thank you, Dr. K.
Yep. Thank you. Good job, guys.
Thank you.